How are you doing today? How's your week been?
Good. It's your weekend.
It was good. Nothing.
My name is Pete Quortrup, and I'm the president of the ALS Living Fund. My personal involvement with ALS began when my wife, Dewey, was diagnosed several years ago. She lived for 9 years, and she passed away recently. She lived for 7.5 years on a trach with a ventilator. When Dewey went for her first appointment with Dr. Verando, the first question he asked when he came in the room was, "What are you doing here?" He said, "Well, you're breathing fine right now. You don't need me today. You will need me. So let's use this time to talk about your disease. Maybe no one's actually sat down and done this with you." Nobody had.
You need a physician that may make a diagnosis or establish a plan of therapy, and some of the plan of therapy varies with the progression of the disease. But at the end is the caregivers close to the patient that provide that care that is important.
I thought a relatively healthy, pneumonia-free life is what people have available to them outside of Dallas. It turns out, I found out otherwise.
When you look at neuromuscular disorders, there are three things that really affects the life expectancy. In spinal cord injury is respiration, breathing, with infection, and pressure sores. And ALS is primary respiratory death.
He said, ALS is going to take away all your muscles one by one. The good news is, these days we have a lot of technology that can replace the things that you're going to lose. We can give you a feeding tube when you can't eat anymore. We can give you a wheelchair when you can't walk anymore. We have computers that can talk for you. You can access the computer just by using your eyes. We have ventilators that aren't much bigger than a laptop computer, and they're very, very reliable. You have a lot of options these days. But living with all that is a big aggravation, and not everybody chooses to use it. He said, my prescription for you today, be happy. Do whatever it takes to be happy. Don't wait, do it now. Because if you can be happy, you might say yes when I say it's time to get a feeding tube. You might say yes when I say it's time to try BiPAP. If you're happy and you want to stay alive, I can keep you alive. If you do all the things I know how to do for you, we have the ability to keep you alive. You'll have to find something else to die from.
I used to tell the patient, I still do, you are like a Mercedes-Benz or a Bentley, perfectly working machine, but no tires. So what respiratory therapy does, what physical therapy does, what speech therapy does is provide the tires for that Bentley to move.
The lungs are our fuel supply. It leads to everything else. And so this is what most people succumb to, is they succumb to lung problems with ALS or with neuromuscular.
If you get to have 50% diaphragmatic function, it's likely that the 3-year survival of those patients is around 30%. But if you're able to ventilate those patients, the 3-year survival will be in the 70%. Quality of life and your length of life is improved by using ventilation. The quality of life at home is dramatically better. And you need to prevent going to the hospital. And what puts you in a hospital? Pneumonia, aspiration.
The problem is they're put on oxygen. They're given nebulizer medications to open up, thought process is to open up the lungs and take a deeper breath, but truly nebulizer medications, bronchodilators just open up the tiny airways a little bit. They may help just a little bit more airflow, but they don't help you take a deep breath. These people need to take a deep breath. That's what they've lost.
When we sigh, we bring all the air spaces to equal size. If we don't do that, because we're weak, eventually we collapse the bottom of a lung, and a lung that is collapsed get secondary infected.
And when they can't take a deep enough breath, they tend not to sleep. The body is working constantly without a rest.
Most people accept when you have trach where you can't swallow properly, where the saliva and the secretions from your sinuses in your mouth and postnasal drip all ends up going down your trachea because you have ALS. That complication means that you will have to live with congested lungs and the risk of pneumonia, and there's nothing much that can be done about it. The truth is that I've learned there are some simple procedures and techniques that are completely able to clear the lungs of those secretions.
My wife and I own a home health agency, have owned this agency for approximately 18 years, employing respiratory therapists to provide care to patients in the home who have ventilator-dependent neuromuscular disease, such as ALS.
What we do is volume-oriented therapy, and it's a goal-oriented therapy. You're treating someone to their predicted inspiratory capacity. If I can get them up to about 60-70% of their lung volume, I can get them off of oxygen, and I can kind of sustain their normal health level. Even their swallow improves, the eating improves, they sleep better.
I basically start off by telling these patients and their families that they are going to be able to do what they've seen us do in the hospital at home, do it effectively, efficiently, and that our whole process, our goal is to get them at home and keep them at home.
When you clear your throat, you take a deep breath, you have that air there, and then you push the air out up through. Well, when someone is not breathing on their own, they're depending on equipment to give them that deep breath. You're just mimicking all those steps with equipment. You substitute taking that deep breath with the T70. You substitute the coughing mechanism with a cough assist, or physically, hand on the chest, hand on the belly, and pushing the air out.
When his lungs are full, I'm pushing it back out.
We do like a 30-minute treatment, and it expands their lungs. It increases that volume that they've lost, and it maintains it.
Get your first big breath, and this is going to auto-cycle your breaths for you.
Because if you don't continue to maintain that volume, you'll get atelectasis.
So we're going to be on this for the next 20 to 30 minutes.
It takes about 20 minutes. Most of it is just the breathing treatment, where the machine just expands my lungs to its full escape capacity.
A lot of people with trachs, we can still have them talking if they were talking before and they think they'll never talk again. And it's amazing how when I go see somebody for the first time, I'll ask them, were you talking before you had a trach? Well, yeah, but they said I won't be able to anymore. 5 minutes later, they're talking. I can't guarantee that with everybody. Everybody's different, but in a lot of cases we can.
Treatment 3 times a day, and I'm relatively clear.
And the main thing is his talking. I mean, I remember he wasn't able to even talk for it. And like I said, that to me was the most important, because you can carry on a conversation,
The other thing that we do is clear the upper air, what we call clear the upper airway. If you can imagine the trach tube that's located inside the windpipe, it has a cuff on it. The cuff is typically always inflated. It sort of directs the airflow. It keeps the air going where we want it to go. When the swallow is affected, the cuff will prevent secretions, oral secretions, from getting down into the lungs. The drawback of that is that those secretions have a tendency just to sit there. You can't get to them. If you just go in there and deflate the cuff, gravity is going to pull those secretions straight down into the lung where you absolutely do not want them to be. So you need to clear that area periodically. The key component to clearing this upper airway is air pressure. We use that air pressure to push the secretions up into the mouth so that you can suction them orally.
While Steve was in ICU, we did have respiratory therapists come in giving breathing treatments using their equipment in the hospital. They typically use a type of catheter that is encased in a sleeve.
I'm not going any farther.
And while they're placing that suction catheter deep down in there, sometimes it can really cause a lot of gagging and quite a bit of pain and uncomfortable. It's very uncomfortable for the patient.
We do cut our suction catheters off just the length of the inside of the trach, because normally
We use catheters that are just 1 inch at the most larger than the tracheostomy tube, because if you use a long suction catheter that you use in a hospital, you destroy the structure or the mucosa of the bronchial tube, and now you open that for infection.
most patients will notice something within the first 3 nights, because I spend the first 3 days to a week really clearing their lungs because they have stuff in their lungs. They're having a lot of problems. Usually by the second or third night, they're telling me, I went from sleeping 2 hours here and there to 8 hours a night. And you see the change in their complexion, you see the change in everything, you see their life changing in front of you, and now they're smiling, now they're breathing better. If they can talk, they're talking better, they're lasting more throughout the day. It's amazing.
And I was diagnosed with ALS in 2009.
I have people 15 years later, they're still going out and seeing movies. Is it a little more difficult? Yes. But you're seeing smiles on their faces and they're still around, and they're still happy with their lives.
I tell the patient that we have a balance in our brain, and one side is the aggravations of any disease, whether it's cancer, multiple sclerosis, ALS, that builds up a weight and tilts the balance in that direction, and the other side is the reasons to be alive. It could be family, husband, church, children, friends, and as long as you have a lot of that, you're willing to tolerate all the aggravations associated with neuromuscular disease.
One of the worst things that obviously anybody could have is the inability to breathe properly, and this procedure or protocol that Dr. Veroslav and his RTs use is absolutely fabulous for keeping the lungs clear.
What I would like my fellow ALS sufferers to know, while the decision to elect to have mechanical ventilation is a deeply personal decision, once you decide to have the surgery done, this protocol is a game changer for a quality of life. I am not afraid of suffocation when using this breathing treatment program.
We've done some amazing things. These people that were supposed to live only 3 years, I'm still treating 15 years later. They have a better quality of life. And a lot of it comes down to that respiratory aspect.
Steve Smith played football for the Oakland Raiders, also a couple of years with the Seattle Seahawks. The thing that's cool about Steve Smith is the way he and his wife work together. She takes unbelievably good care of him, and he smiles at her. And that's two people working together to make a good thing happen. Steve's had ALS for 15 years. He's been on a ventilator for over 10 years, and he's not ever had pneumonia. That's remarkable.
I haven't been to the hospital in the last 7 to 8 months. I have had, other than going to Dr. Veroslav once every 4 months to get my trach and my PEG tube changed.
My name is Tony Zarvu, and I have had ALS since 2013.
Tony Zarvu, he's got a defiant attitude about his ALS. He intends to live with it for a long time.
I just refinanced this house. I pushed the envelope with Medicare and got a ceiling lift paid for.
He still runs his company when he can move only his eyes.
I have a bet with Stephen Hawkins that I will give him a run for his money.
I've been with Tony for over 2 years now, and I've been to a couple of meetings here, and it's really awesome to be a caregiver and be a part of this team.
I look at respiratory therapists and caregivers as the most important individuals and the care of patients with neuromuscular disorders. Respiratory therapists cannot be replaced. They can teach other ones, but more importantly, they can teach the caregivers. Once you're on the ventilator, somebody have to do it at home. They can come and treat the patient and help the family treat the patient and educate them how to treat the patient, but somebody have to be with the patient at home 24 hours a day. You don't have to be rocket scientists. This is not rocket science. It's just learn and do it.
You know, all these pushes that we do, this inspirational push, you know, from the side on expiration.
Here we are in Dallas and applying these amazing and amazingly effective techniques, yet in the wider respiratory therapy community, there's a complete lack of knowledge about what we were doing.
We could be saving lives simply by teaching people how to give these treatments, teaching respiratory therapists to come into people's homes and providing the service.
To see those patients when they come from acute care or wherever, and they have all these secretions, they have these problems, and then by the time they're ready to discharge and go home, to see it work, to see the light go on, it's been one of the most rewarding things of my professional career.
You know, there's no cure for ALS. It's just make them comfortable. We think totally different. We want them to have life back. Just because they're on a vent, on a trach, doesn't mean that's the end of life. In order for that to happen, other docs, other physicians, other therapists, other clinics, I mean, home health, the government, they all have to get involved, because if they don't see that this can be effective, it will go nowhere.
And it has been a dream. You know, it's just a dream. Every patient, every person who came through, we are the beneficiaries in a way that they enriched our life.
People ask, what would I like other patients and caregivers to know about this protocol? That's a simple answer. I want them to know it exists.
I have a friend that told me that he didn't know the definition of love until he had to take care of his wife. Most of the time we learn love given because we want to get back. That's not love. That is business. Love is giving.
We want to improve the ALS respiratory care standard nationwide. You can help. If you are living with ALS, you can share this film with your local support group or with your doctor. If you are a healthcare professional, we can help you bring this care model to your patients. If you are an ALS organization, we can help you bring better care to those you serve. And if you are with an insurance organization, we can help you improve ALS care with lower cost. To learn more, email us at breathingeasyindallas@gmail.com. To support us, visit thealslivingfund.org and select Donate Now. Thank you.